Great.
20 online, yep.
Okay, fantastic. And can everybody hear me now? Yep, great. Hi, I'm Steve Jand. I'm co-director of health systems at the George Institute for Global Health. And my colleague, Bindu Patel, who's a senior research fellow at the George Institute for Global Health. And we'll be running the session today. And it's the culmination of our project called Multisectoral Collaboration and its impact on health and wellbeing. And we'll have a number of presenters, and I'll introduce them later on in the session. But before we get moving, I'd like to ask Bindu, since she's based in Sydney at the moment, to do an acknowledgement of country.
Thank you, Steve. I would like to acknowledge the Gadigal people of the Eora Nation, the traditional custodians of this land from which I'm presenting. I would like to pay my respect to the elders past, present, and emerging, and extend that respect to any Aboriginal people present. Thank you.
Thanks, Bindu. Yeah, look, this is, as I said, a session that we're sort of presenting some of the findings from our study on multisectoral collaboration for health. It's a study that was funded by the Australian Prevention Partnership Centre. And the format for the session today, so we'll give a short presentation, 20-25 minutes. It'll be mainly Bindu presenting some of the findings from both a systematic review that we've done as part of this work and a case study of an example of intersectoral collaboration that's been happening in Australia for the past several years. It's in Tasmania. It's called the Premier's Health and Wellbeing Advisory Council, and we've been studying it for the past year or so, and we'll present some of those results. Following that presentation, we've got three discussants, Joe Mitchell, Fiona Haye, and Patrick Harris, who I'll introduce properly when we get to their discussion. And they'll give short comments about their reflections on our findings. And then we'll have at the end probably about 15 minutes question and answers. So please feel free during the presentations to put questions into the chat box, and we'll put them to either myself and Bindu or any of the discussants. So hopefully we'll get some good discussion going in this session. So it's not meant to be just the presentation of our findings. I hope we can generate some interesting and new ideas, and I know a lot of people in the audience come from some experience from policymaking point of view, as well as research in this area, and I'd love to hear some of your insights. So just a bit of context for this study. This was a study, as I said, was funded by the Australian Prevention Partnership Centre. And it was a topic that was actually put up by some of the health policy partners. So some of the partners include ministries of health around Australia, and so they put up this topic around multisectoral collaboration for health, and in particular the role of health in all policies, which is in health promotion. And for those of you who don't know, Health in All is an initiative. Yes. Bindu? Sorry.
Steve?
Yes? Oh, you can't hear me? Bindu?
We can hear you. I think the rest of us can hear you. So but maybe keep going with Bindu's.
Okay, sorry. Yeah. I thought so Health in All was is a WHO initiative to sort of provide guidelines for intersectoral collaboration, and it's had sort of mixed success internationally and in Australia. And so one of the things that we wanted to explore is how well multisectoral collaboration works within a policy-making context. So the aim of this particular study was to understand how such collaboration for prevention of non-communicable diseases can be effectively institutionalized into government decision-making. And some of the specific objectives of this have been to identify what are the institutional characteristics that enable such collaborations within government to work effectively. Who are the key players, agencies, departments, individuals and community stakeholders, and what role can they play? How has COVID shifted these institutions? What incentives do stakeholders face and how can they be aligned? And how can we identify potential winners and losers from individual collaborations? So that sort of is the context of the study, and it was done in 3 parts. One was a systematic review. The second was a case study of the Premier's Health and Wellbeing Advisory Council, and third was a stakeholder workshop, which was conducted about a week or so ago, which we're still in the process of analysing. So with that, I'll hand over to Bindu to present the findings of some of our work.
Hello. So I'm going to first start off by talking about the systematic review. It's going to be quick and a brief overview. More details will be, you can come to us for more details and will be published in a paper. We're going to look at the empirical findings of multisectoral collaboration and its impact on health and well-being outcomes. And in order for us to determine the effectiveness of multisectoral collaboration, which is a complex health intervention, the nature of the evaluations were heterogeneous and complex, as well as the evaluation. Therefore, we used the PICO framework to help formulate questions for our review. So what was the target population, the health and well-being problem that's being addressed, and the intervention was 2 or more distinct sectors working together to improve health and well-being. The comparator was only used for quantitative evaluations if there was one. There were some observational studies. And looking at the outcomes as health and well-being outcomes, but as well as looking at environmental change or social determinant change and policy and legislative change more at the structural levels. So I'm not going to go into detail, but we started off with 6,015 records, papers, and only included 17 that looked at, there were empirical studies that meant that they evaluated either quantitatively or qualitatively health and well-being outcomes through collaboration. So in order for us to synthesize this data, we put together a logic model. And this logic model was to help us to look at the activities and the inputs that resulted in some of the measurable outcomes, as well as based on the evaluation findings. So the integration of both the inputs and activities and the resources and outputs from the formation of the multisectoral collaboration, as well as the evaluation outcomes. And we classified according to different levels of impact, short, intermediate, and long. And that was, and we'll go more into details in a later stage, but from that, the results of the population and the problems was that we found of the 17 articles, 14 were in high income countries, 9 in the US, 2 Australia, 1 Canada, 1 UK, 1 Finland, and 3 in low middle income countries, Nigeria, Fiji, and South Africa. What was interesting that is that 2 papers that were in Nigeria and South Africa and low income countries was on communicable disease, while the rest were on non-communicable disease, addressing obesity and cardiovascular disease related risk factors and mental health. There were 2 papers on social determinants of health, inequality, that addressed inequality and environmental issues. Now, I wanted to just give you a glimpse of the different terminologies that were used for collaboration. So it could be anything from collaborative partnerships, multifaceted intervention, public-private partnership model, health in all policies, which many of you have heard of, collaborative, coalition, collective impact framework, cross-sector collaboration. And these are just the few that we came across in our studies that evaluated impact. Now, going on to the findings, the way that we addressed our impact was classified by short-term, intermediate, and long-term. And we used a matrix to help identify impact based on the length of time of the program or valuation, level of impact geographically. So was it at the local, regional, state, or national level? Individual population level change, or the type of impact that was it sustained over time? Did it have legislative change, governance structure change, policy, and initiatives that were formed and resources developed? So short term, we had 6 of the 17 that were short term outcomes, 7 out of the 17 that were intermediate, and 2 that were long term, and no impact for 2. Now, the next slide is quite busy, and I apologize for this, but this was to exemplify and demonstrate the complexity of the studies and the papers that we came across. They weren't uniform in any way. The evaluation was very heterogeneous. The collaboration was also heterogeneous and complex. So I'm going to go through quickly the 4 quantitative studies that we retrieved and had an evaluation done. And it ranged from no association to long-term. So in the no association, there was no impact in the collaboration, was looking at state-level policies on nutrition and physical activity, and through surveys done through staff. However, this was a cross-sectional design in the study, and the conclusion, the surveys were done after the policies were formed. So the policies were already in place. Therefore, there was no correlation in the cross-sector collaboration of the staff on the different organizations. The next program, the evaluation that was done, was a public-private partnership in Nigeria on a controlled randomized trial looking to screen TB and increase the notification of TB in these communities. There was an increase in TB notification through this public-private partnership, and there was a large community-based organizations that formed the collaboration with the health sector, and that was key to the trial of having these community-based organizations as their multi-stakeholder entities collaborating with the health organization. We don't know beyond the short-term impact. It was a trial done for 1 year. The next one was a state-level policy systems environment intervention that was looking at increasing access to healthy foods. And they were looking at REACH. It was a policy entity that was implemented throughout West Virginia in the United States. And they were looking at REACH of increasing healthy foods in school cafeterias and farmers market. There was an effect and change. There was an increase in healthy foods in cafeterias as well as farmers market access to these foods. However, the funding and the programs beyond the intermediate effect of the funding period was unknown. The next one was on the famous North Carolina project, which was based on it was a community-led demonstration project that was started by petitions at the community level that led to national level legislative policy change. And that went on for several years, over 20 years, this program has been in place, and led to large scale reduction in mortality of CVD, reduction in smoking, as well as cholesterol and BP. This was through community engagement and demonstration and political will and funding and initiation of organizations at the community level. Now, I'm going to quickly go through, I'm not going to go into any kind of detail, But the findings from the qualitative study were that there was one no impact, one intermediate, and one long-term. Now, in regard to the qualitative studies, it was difficult to classify them and the impact because many of them were dependent on processes related to stakeholder opinions and satisfaction with the intervention results, and also the processes of the interventions and opinions of the intervention carried out. The mixed method were generally more easily interpreted since the impact of the qualitative results generally supported the quantitative. So there were 5 short-term impact papers and 5 intermediate. Now, the degree of impact, short, intermediate, and long, were dependent on the governance structure and actions of the collaboration. That included activities that were relating to connection formation of the collaboration, resources such as funding, human resources, and monitoring and evaluation, and political will, as well as other structural governance structures. Now, I'm going to go on to, this is a good segue into our case study. This case study, as Steve mentioned, was a body that was established in 2017 by the Tasmanian state government to identify, prioritize, and coordinate whole of government programs to promote health and well-being along the lines of WHO health and well-being, health in all policies. So what we evaluated this program to see what elements were currently in place for effective collaboration, what were the perceived impacts of the council, and what elements were needed for effective collaboration across sectors over time. Now, in order for us to answer these questions, we conducted semi-structured interviews with stakeholders. There were 11 interviews, 7 council members, 2 were from the Department of Premier and Cabinet, and 4 were and there were 4 others members, and then 4 non-members from health, finance, planning, and business. We did document analysis as well as ethnography, observation of the council strategic meeting in March. So now what is interesting about Tasmania is that their context, it's a small jurisdiction that actually influences and enables effective collaboration across sectors. So one of the quotes was, one of the beautiful things about Tasmania being such a small place is those relations are long-term. It does open doors for someone like Graham, who's the chair of the council, to go to the Premier and say, look, I'm the chair of the Premier's Health and Wellbeing Advisory Council, so I would like to have a conversation with you about whatever. In some ways, Tasmania can be tremendously helpful in terms of enabling that engagement. Another key structure that was put in place was the Tasmania Statement. This is the signing of the Tasmania Statement more recently. So it was signed in 2019 and re-signed more recently in 2021 by the Premier, Deputy Premier, and the Chair of the Premier's Health and Wellbeing Council, which we refer to as a council. And a quote was by one of the stakeholders, there are many that have been tangible outcomes in terms of Tasmania's statement, I think in terms of funding some initiatives. Now, to get to this stage, Tasmania had a long history of bipartisan support for preventive health. We started around 2011 and 2012. So in 2012, there was a bipartisan support of Joint Parliamentary Select Committee on Preventive Health. That changed this, that shifted the thinking in Tasmania and working in silos to health in all policies approach on preventive health. In 2015, they had their first Healthy Tasmania strategy that led to outcomes of health and well-being objectives of land use planning and approval acts in 1993, which was one example. Now, another element that is currently in place for effective collaboration is government, the strong impetus for action in improving well-being. So the current premier that was elected in 2022, who was a deputy premier prior to this, a strong advocate. So within 2 weeks of the premier becoming a premier, he had a statement on progressing Tasmania's first well-being framework. We will take the next step to develop Tasmania's first well-being framework. To do this, We will engage with Tasmanians, ensure their well-being priorities and government priorities supported by the right targets, measures, policies, and services. Well-being can mean different things to different people, but it includes economy, health, education, safety, housing, living standards, environment, climate, social inclusion, connection, identity, and belongings, good governance, and access and services. The key authorizing environment to successfully implement well-being frameworks. Another element that has been in place for effective collaboration is the Premier's and Health Wellbeing Advisory Council's governance structure. So the main function is to provide independent advice and recommendation to the Premier and Cabinet on issues relating to health and well-being. So over time, they've built strong relations and connections through persistent advocacy. They've influenced policy and strategies and initiatives through recommendation. I suppose, a quote, I suppose in terms of something like Healthy Tasmania, which has completed the first 5 years of that. So the council certainly had some influence and input at the point of review of that strategy. The perspective from a non-member and non-government unaffected the council, there is also limitations. Limitation that they're purely advisory, so they don't have a budget, they don't run programs, but they do have the ear of the Premier. So what are the perceived impacts of the council? So there's indirect impact. It's mostly used as an advocacy tool to promote health and all policy approach and equity across sector. I'm not going to go through the quote just to save some time. And direct impact is no measurement of direct impact. There's no direct action plan or implementation plan. The significant outcomes, but obviously it's not. It doesn't really do anything on its own, and the influence of that Tasmania Statement is to be seen. So the government's view of the impact that the council has had, it's raised awareness to influence legislation, policy, and strategy. So the first is the wellbeing framework that is being developed with indicators across agencies to measure impact. The Local Government Act, a dialogue on health and well-being. So this is a quote from a member who's part of DPAC. We, the council, have been advocating for 2 years for Tasmania to have a well-being framework with indices and outcomes. The Premiers announced that. The council have also advocated for Premiers' priorities, with the Premier will announce shortly. So the council have huge influence. The council have the ability to influence every element of government policy. Council is not accountable for government policy. Their job is not to develop government policy. Their job is not to measure where agencies are delivering. So their view is that they have had influence and they're purely advisory. So I wanted to share also what an independent non-member that we interviewed, that's the CEO of a business entity, said about the council. I have had no line of sight of them at all, other than being invited to an event from time to time. I think it's a real missed opportunity, and I'm not sure they understand the opportunity that business could provide them. We presented a number of health ideas to government over the years. Some they have taken up, some they haven't, which is fair enough. So I'm going to go on to elements needed for effective collaboration across sector partners. So it's establishing funding model for collaboration. So government, a quote, government funded annually through appropriation from Parliament. This is part of a stakeholder, part of the Treasury, works closely with government. It's difficult to establish long-term funding models for agencies. Most agencies receive a fixed amount of money annually unless new initiatives. NGOs and others grant funding on fixed-term basis to deliver outcomes and establish processes. So a quote is that I don't think government is very good at measuring program success and evaluating programs and modifying them. I think part of that goes to just the annualized structure of it all and the short-termish in political cycles. So it's complex in regards to how the funding takes place and the governance structure for Tasmania. So it's based on political will, external factors. So the time frame of election cycle can affect budget priority, short-term commitment, dependent on fiscal policy or strategy that is influenced by political will. Decision-making is supported by business case influenced by politics. The short-term national measures to do with cost of living pressures are putting short-term money into people's pockets. So what are the elements for effective collaboration across sectors? Does Tasmania have an intersectoral governance structure for funding? Governance structures in Tasmania, according to interviews, is evolving depending on the problem that is being solved. So it's complex. Government agenda priority can be reactive and dependent on external factors that can be difficult in solving long-term problems like chronic disease. What is also needed for effective collaboration is support required from different heads of ministries and agencies, which has been difficult to engage. I suspect that often they're blocked unless they're pushed really hard at the agency level. Interesting, have some senior planning colleagues in meetings last month. They are understandably defensive in that partnership hasn't been the focus on strategic planning settlements in cities and communities to achieve and promote health outcomes. So the political economic constraints to effective multi-sectoral collaboration. From the members' perspective, the council members' perspective, the ideal governance model that they're trying to, that is part of their goal is to have a more authorizing environment from government. The council like to support agencies to be able to create an environment for agencies and actors and how to work together and overcome the barriers of working in silo with their own objective and remit. To bridge sectoral silos, to work across different layers of government with different sectors, to address structural, policy, environmental, structural barriers to health and well-being as an independent entity supported by government. Council is a link between agencies and the Premier, a process of how to effectively collaborate across sectors and overcome power dynamics. So the council, according to the members' view, what elements are needed to sustain this collaboration over time is that they've laid the foundation for a lot of these key policy levers. They started with holding a Health in All Policies Forum in 2019 that was attended by over 100 members across sector and governments and private businesses. The Tasmania Statement, the Healthy Tasmania 5-year strategic plan that was recently developed and launched has a research and evaluation framework, governance framework, Healthy Tasmania Action Plan, and a new Healthy Tasmania Fund, which the council was involved in advising on. A recent submission of recommendations to the Tasmanian Active Living Coalition on Tasmanian state planning provisions that was recently submitted, and submission to the Tasmania State Service Review, which I'll go into more detail what they have advised on, which is a mechanism for action. The Premier progressing the Wellbeing framework. So this was a state service submission by the council that is a key finding of the review as well as the case study evaluation, which was recently submitted to the government. And the government is going to be using this advice in their wellbeing framework. It's appointing senior independent commissioner type role whose function is to ensure all government decision making considers health and wellbeing outcomes now and into the future. Embedding a health and wellbeing impact process into budgetary decision making. Establish a participatory budgeting process to allocate some of the budget for health and wellbeing. Require departments to independently produce long-term insights. Briefing to be tabled in Parliament, proposed to introduce new reporting requirements and legislation, develop shared responsibility for health and well-being across government through development and measuring of health well-being indicators, including the inequality gap between segments of population. So this is just a word cloud on one of the key themes of health in all policy and framework. So we had a stakeholder workshop with the council and a few other key stakeholders last week and presented our results to them. And a lot of the key mechanism for changing how Tasmanian government and the population think about health and well-being and social determinants of health, they have been able to change and shift that thinking. And a key entity that they've been able to change their thinking is government. and it's bipartisan. So they've done the first part. I guess the next part is the critical part in how to roll out the implementation of the Wellbeing framework. So conclusion, future of multi-sector collaboration and action from our review and case study is the need for community engagement and political will in combination. Funding being the key driver for resources and continuation of programs and initiatives. So support from state government is needed for system change, along with political will. Need for mandate from government or authorizing environment to make system change and promoting co-benefits, so accountability structures to be developed. Development and implementation of intersectoral governance structures from different levels of government and private sectors. So communication and understanding of goals related to health and well-being across sectors. And so a quote is, no shift in culture around existing way of doing things. So there needs to be the structures have to change in order to produce the tools for action. Measurement of key indicators, integration of monitoring and evaluation. Now, in relation to the council itself, a conclusion was that the government liaison officer as part of the council was an enabler and a barrier on the advice for development and implementation of intersectoral governance structures. However, they need more authorizing environment to promote health and well-being approach in a more actionable way. Thank you. I'd like to thank and acknowledge the Australian Prevention Partnership Centre. And Kelly Zhao, who was a research assistant who was instrumental in the systematic review, as well as the coding for the evaluation. The project working group co-investigators, Dr. Patrick Harris and Associate Professor Fiona Haye, and the Premier's Health and Wellbeing Advisory Council members, Graham Lynch, Julie Williams, and Verity Cleland, and stakeholder informants. Thank you.
Great, thanks, Bindu. That was very comprehensive summary of the work that we've been doing in the project. So we're going to have three discussants, just sort of give us a very short reflections on some of the findings and perhaps some issues for further discussion. So the first person I'd like to introduce is Associate Professor Fiona Haye, who's the Director of the Health Equity Research Development Unit, which is a joint initiative between UNSW and the Sydney Local Health District. Fiona is a health equity focused applied public health researcher with over 20 years experience internationally working with health and other sectors to strengthen the consideration of health and health equity in decision making. So Fiona, if you could just sort of give us about 3 minutes of your thoughts on this, that'd be great.
Great. Thanks, Steve. I think a real strength of this project is its in-depth nature, and its clear focus on identifying outcomes, and it's really demonstrated how you can actually break down what's happening in quite a complex process and system. And I think the systematic review and the case studies showed that. So it almost feels a bit overwhelming when you kind of go through all those findings. But I think it's really interesting to see how you can actually unpack it. And then you can potentially identify those areas that you could be influencing. And then I think it also clearly illustrates how, even though you can unpack and pin down those different aspects of it, it's really important to kind of see it, that it's happening within this complex, open, adaptive, emergent system. So we saw, particularly with the case study, how you've got those different entities within the system and the attributes that they have and how they interact. So we had the actors, in some case, they're champions, they have varying sort of understanding, beliefs, sort of types of power. And then we've got the structures, such as the council that enable action. And then we've got those events that happen, such as budgets, election cycles, and so on. And it's all happening within these sort of institutions with particular kind of rules of the game. And they enable and sometimes constrain action. And so we heard like the example of the Tasmania being this kind of small connected place and how that interacts with that. And I think what it does is it really powerfully illustrates how intersectoral collaboration and action for health is a political project. So rather than thinking about it in a sort of a technocratic way that we need to have just certain building blocks, we need to think about that kind of context within which things happen. You know, we saw those kind of building blocks of, I know, the council, the legislation, the Tasmanian Statement, and they're necessary, but they're not really sufficient to enable change. And so that means that we need to pay attention to those politics in that local context. You know, things also such as, does health have currency in that environment? And I think this all reflects the wider body of experience and sort of in health and all policies, and also, you know, political and policy science. And in terms of, I don't know where that leaves us, I think there's a continuing need for this type of research, and particularly when it's carried out in an interdisciplinary way. And again, I think that was actually one of the strengths of this project, is the investigators did come from different disciplines, and that sort of brought different aspects to be able to kind of unpack the problem. I think one of the key next challenges is really thinking about that sustainability and institutionalization. So how do we get that sort of equity or that intersectoral action infrastructure embedded, you know, so that it does become part of that sort of rules of the game? I think there was a quote that Bindu had before about, you know, that there hadn't been the culture change yet. So I think that kind of thinking about, you know, getting to that next level, which takes time. You know, I think the Tasmanian example is, you can see that it's at a certain stage of development and it's continuing to change and develop. And then the other thing it made me think about is our roles as academics, as, I don't know, policymakers, practitioners, and how we interact with that. So as we gain these insights into like how, particularly how the politics work, you know, we can work out maybe how we play that game as well. But sometimes I think that also creates tensions in terms of kind of our values and what we're ultimately trying to do. You know, I've noticed sometimes in health and all policies that there's a bit of a drift away from talking about equity and difficult things at times, and maybe, you know, focusing on those small gains, you know, it's hard to then think about that transformational change. And I'll leave it there. Thanks.
Thanks a lot, Fiona. I'll ask Joe next to give some comments. So Joe Mitchell is a senior advisor with the Prevention Centre and an adjunct associate professor in both School of Public Health at University of Sydney and the School of Population Health at UNSW. Joe's professional expertise is in policy and the delivery of statewide services and programs for prevention. The most recent government experience was as a senior executive with responsibility for population health in New South Wales. So, Joe, over to you.
Thanks very much, and I agree it was a very interesting presentation, and I think that there are sort of two main reflections that I'd like to sort of add to the discussion. One is around the nature and scale. I mean, I'm going back right now to the review that on you know, when you went to the literature, and so I thought it was telling that out of, you know, some 6,000 odd articles that were originally identified, only so that sort of whittled down to 17, and that the nature of those studies sort of focused particularly around health, and I understand the reason for that. But when we're thinking about sort of intersectoral collaboration, coming from a health lens, gives it a very particular framing, I suppose, but also the scale. So that the studies tended to look at, you know, smaller scale interventions, and that's probably in relation to, you know, it's obviously in relation to the way in which you know, some of this work is reported on in the literature. The reason that I sort of raise this as an issue as well is that I think that it's important in prevention that, you know, we're also, we often look at programmatic responses or interventions, and I think that, you know, that this audience would be very understanding that it's actually the policy and regulatory approach where I think we can get sort of better population level gains, but of course that's much more tricky to achieve. So that's my first comment. My second comment is in relation to the health in all policies framing, and what really, and sort of in the introduction there was a discussion of, you know, winners and losers, and also I was really struck by that that quote which talked about that people were defensive. So that sort of defense, people defensive about sort of their patch and the way in which thinking about health could actually impact on the business of other government agencies. There's been quite a bit of discussion lately around, health in all framing, and a slight changing. This is a reflection in the Lancet in the last year or so about changing the sort of the framing from health in all to health for all. And what they're talking about there is not just about, what the impact of other policies and in other agencies can make on health, but also going back in the opposite direction about the way in which what health does within its own bailiwick can actually have broader impact in other government, for other government policies. And so I think that that's where the concept of co-benefits is really helpful in the prevention space as well, so that there's a sense of the way in which health impacts more broadly, but the way in which those other broader policy areas impact on health as well. So it's much more of a mutual benefit approach. So just finally, I think it's sort of that sense that wellbeing frameworks is kind of like flavour of the month, and so we know that that's sort of happening at an Australian level, Australian government level, and so it seems as though that as a mechanism might be a way of being able to tie these things together as well. I think that the development of those concepts of wellbeing frameworks and wellbeing budgets are going to be important. But, of course, the proof is always in the pudding around, and I think this was reflected in the reflections around the council as well, is about, the way in which those structures are established and the mechanism and I suppose the real decision-making power and where that lies will impact on, the kinds of benefits that we'll see. I'll leave it there and allow others to reflect as well.
Thanks a lot, Jo. The third discussant is Patrick Harris. He's a Senior Research Fellow and Deputy Director at the Centre for Health Equity, Training, Research and Evaluation. He's an applied public health social scientist who's interested in complex real-world policy issues. He focuses on research that makes a difference at the local level, as well as connecting with national and international research policy and practice. So, over to you, Patrick.
Hi, sorry, I'm sitting in a cafe, so I hope it's not too loud. That was great. I thought the whole presentation was fantastic, and the work you've done is really great. But the owner's points, wow, really concisely to say everything's in my head, so I don't need to repeat that, or I may touch on those things. And Jo, I think your experience as a senior health bureaucrat and policymaker is fantastic, and I think the points are well made. I've got two things that I think are worth considering, and they overlap with what's been said. This research is just another example of how to break down the complexities of the realities of policy making, and I think you've done a really fantastic job. It's been a great experience for me to sort of see it happening as an advisor rather than sort of getting my hands dirty doing it as usual. So, and it's been interesting to see you come through it basically with the same dynamics that Fiona was talking about and are written in all of the research. Right? So you come up with a way of looking at the problem that reflects the reality of the problem, and that means it's a real problem and there are real solutions to it. And I think that's to be commended. Going back to Jo's points and some of Fiona's points, the real interesting thing here is that for a long time, health's been interested in sectoral policy making. For a long time, we've approached it probably with a sort of bit of a weird lens for people who are working in public policy, because we've said everything's about health, and it is, but at the same time, it's actually all about public policy, right? So what you've demonstrated once again, and this is to Jo's point, is come in through the public policy lens. That's the most powerful thing to do, and then add value with a health perspective on that, with that public policy lens. And I think you've demonstrated that. I think one of the challenges with our sector, the health sector in this interdisciplinary space, is a warranted and needed discussion about health outcomes. And this is where Steve's economics background is really useful. But is it actually possible to really evaluate those outcomes over such long periods of time and in such complex, value-laden, difficult policy environments, right? Because it's almost like when you do people who are working in public policy realise the challenges of all this, the churn and the mess and the trade-offs and all the ideas. So in a way, you know, that it's really hard for us, particularly as academics, you know, I think, to come in and say, look, well, what's the outcomes of your work? Did you actually have an impact on health and well-being? And that, I think, is reflected in the literature the literature review you did. And I think the challenge for us as a sector is to come together in a multidisciplinary fashion with people who are economists, with experts in policy making, who are interested in political science, all this other stuff, to really come up with a way of looking at the institutional dynamics and the outcomes of that, if we can. And that's really the next step for this area of work. One last thing I think hasn't probably been reflected on that much is the importance of, when you get to do this work, the importance of governance, and the importance of different approaches to governance. So the governance literature and people who are working on governance, regulatory space, are great on this, is about different approaches to thinking about how governance is made, so that, I went too technical, but sometimes it's top down, other times it's sort of, not hierarchical, and it's a bit messy. It all depends on what sort of issues are coming up. And I think you found that in Tasmania. They were talking about how the governance needs to respond to the problems, but without the governance, the problems don't get addressed. You know what I mean? So it's a bit of an interesting dynamic there. But what I'm saying is governance is a really important space for this area of work to focus on. And the next one is really underneath governance lies power, right? And addressing power, both in the sense of making communities healthy and more empowered, but in terms of policy making, it's the power to shift and address quite entrenched, what we call path-dependent systems, and how you reorient those systems to be about good public policy making, and health is part of that discussion. So that's my points. I think the whole project's been great, and Bindu, really fantastic piece of work, Steve as well, and it's been a pleasure to be involved in it. Thanks very much.
Thanks a lot, Patrick. That's great. We've got some questions. There's one that's come from Renee Mbezi, and she says, thanks for the presentation. Did the research include a comparison to South Australian health and all policies? It would be great to know any cross-jurisdictional comparisons, and keen to learn for Victoria. Bindu, maybe I can answer that, because part of the history of this study was that it was originally going to involve South Australia health in all policies, and we were working with some of the people there. Unfortunately, COVID hit, and we had to put that particular case study on ice. But nonetheless, I know that has been work done in the past, including stuff by Patrick, Palmer Williams, and Fran Bohm in relation to the South Australian context. And so there is stuff around. I don't know how recent it is, but certainly that might be something that we could sort of rejuvenate for a future study. But at the moment, what we've done is really just focus on the Tasmanian Premier's Health and Wellbeing Council. Did you want to add anything to that, Patrick? I think there is a lot of work done, and like you say, it's been a lot of very focused work on South Australian health and policies. I think that's fantastic. I think similarly, there's been a lot of work done by myself and others in New South Wales and other states around, going back to the idea that maybe it's about public policy, not necessarily always health and all policies, but it's also comparative. There's some really interesting work in Victoria going on around climate change at the moment and public policy that I think also, I also think is relevant. Well, I guess moving on to Steve's point and going back to my point about the need for sort of a multidisciplinary, larger research agenda, I think it's definitely, there's work going on in each state and territory and internationally that we can really apply this clearly important approach to thinking about that problem.
And it's an interesting research program. The challenge is whether or not who's going to fund it. So I don't think the NHMRC and the ARC are quite there yet in terms of seeing these connections between sectors, even despite that being the reality of a lot of policy making that's going on at the moment. And I think we need to, and this is maybe where TEPSI can lead, is we need to be getting together to really develop a research program around it. I think there's great opportunity, and perhaps we can sort of force the arm of these Category 1 agencies to start funding it, as opposed to sort of keep throwing things in there and not getting much payback from it. However, had said that, my colleagues Sharon Friel and Frau Bam are also doing great work on this, and I think they've both been funded by both those agencies to do fellowships, etc. in this space. So a lot around climate change and post-COVID recovery, and that's okay, that's good. But I do think we need to have a connection between all of us to really tie the sort of strings together and develop a really comprehensive approach to evaluating what's happened, and also sort of policy comparison type thing across each of the states and jurisdictions and states.
Thanks, Patrick. Next question's from Sarah Dion. Thanks so much, Bindu, for a comprehensive and informative presentation. Will you be able to give us some examples of the sectors that you found working together, please? And another question is if you found any governance framework used or recommended for multisectoral collaboration. Thanks so much. I guess this is a question for Bindu, but I want to open that up to some of the other discussants as well to see if they have any experience that they could share in relation to that. So, but maybe Bindu first.
Thank you, Sarah. So some of the sectors, a lot of the programs were on obesity, addressing obesity. So schools were involved, corner bodegas, the food retail entities. Also agriculture, farmers, and a lot of civil society organizations, that's religious groups and other groups that came together to collaborate with the schools or the food retail. But I can give you more detail. I can email you more detail on the sectors if you like. And the governance structure framework that there are, and the one that I used to help to put some of the findings together was the WHO Health and All Policy Governance Framework by the Observatory. That was more recently, I think, published. I'm not sure what year, but I can send that to you as well. But I'll leave it to the others to input on other governance frameworks out there.
So any of the others have any experience of these sorts of mechanisms?
Yeah, look, I'll just make some, I'll just make some quick comments. Having been involved in a Premier's Council in New South Wales, and also having been involved in a Premier's Priority, which was focusing on overweight and obesity for children, and reflecting on the differences between those. I think that, one of the things that's incredibly important for something like this to actually stick is that there has to be a real passion and engagement in the issue by the decision maker, I'm talking the head, like either the Premier or the Minister, to be able to make something like this work. And so I have seen different circumstances where there is that commitment and you see things, doors open and things change. And so Premier's Priority is a good example of that, where because of that imprimatur and because it took a focus which looked at measuring impact, and that was a process which had its weaknesses, but it also had its strengths in that it kept it on the agenda. And so they used the approach to the Premier's Priorities in New South Wales. They borrowed from the UK experience, and had very clear expectations around the way in which you reported back on progress. And then if it wasn't going in the right way, there'd be you'd have much more regular oversight in terms of the work that you had. So there was that sense of, in that experience, which also brought different government agencies together, it was a really enabling environment, and it did sort of allow different kinds of conversations to happen that had happened in the past. But that was sort of very much based on, one particular priority, and there was an expectation that those things were reported on, and that things happened across sectors as well. But then, once the spotlight comes off, then those things fall away as well. So there are strengths and weaknesses, I suppose. But it's tough. I don't step away from the fact that trying to get this high level alignment and policy congruence, I suppose, across government agencies it's a very difficult thing. And I agree with Patrick that this is an area in systems approaches.
I think we've lost. We just missed the last bit there, Joe. It sounds like you were winding up to a big point.
Oh, my big point was that I agree with Patrick that this is an area where I think that there's a lot of opportunity for more guidance and support and tools and resources to help us to move in a more sustainable and sort of embedded way, because it's an area that people have been interested in, since before the Ottawa Charter, but it's been difficult to actually get traction in a long-term way.
Right. Thanks.
So this is a great project to help us rethink and re-engage in this.
Thanks. Look, one last question, and it's from Kenneth Yakubu. Great presentation, Bindu. I would like to learn more about the authorising environment for multi-sectoral collaboration. Did you get a sense of how state actors were able to achieve legitimacy and trust within this environment? And I guess this is a question for Bindu, but again, if any of the other speakers have any thoughts, please jump in.
In regards to our case study, as Joe just mentioned, is that passion and interest in addressing health and well-being is key to form that trust in that environment. So they need that interest and passion. And that was brought up in a lot of the interviews at high levels, saying that they're passionate about addressing health and well-being, from finance to treasury to business. So that to me, that would be a key factor.
Yeah, I agree. I think just adding to Bindu's point, I mean, one of the unique characteristics of the Premier's Health Wellbeing Council and what's enabled it to in a sense persist for an extended period of time is the chairs, the personalities involved, in particular Graham, the chair of the committee. So I don't know how you can sort of generalise that sort of lesson. It's a bit hard to sort of clone Graham, but yeah, it is important that there are people within that sort of environment who are strong champions, who have the ear of government. And the remarkable thing about the committee is that it has survived changes in Premier, and which is, I guess, something that sort of puzzles me a bit, because I always feel that intersectoral collaboration is an area where the biggest gains are possible in population health. And it would almost seems to me, perhaps a bit naively, that it's a no-brainer that it is something that the governments should support, and it should have bipartisan support. But to some extent, it seems to me that it's also a bit of a political football, that it often doesn't get that bipartisan support. That sometimes when there's a change of government, the momentum for this sort of thing drops off. So it is curious that sort of bipartisanship, that strong support for something that seems so self-evidently important isn't there. But anyway, do any of the other speakers have any comments?
No, I agree. I think that's absolutely right. I think it's interesting, Steve, from your take as a the ultimate challenges for us is, again, that goes a bit to my outcomes discussion, but also the idea of multidisciplinarity. How are we linking up to to what the economy means for society, right? And that essentially is where that what you're talking about, that sort of struggle for connection and interface really happens. And it's really around cabinet decision making around treasury and treasury that ultimately where that plays out. And that's, I guess, the game. And it was interesting to me at the end of the discussion we had with the people in Tasmania that we were sort of off the top of our heads coming up with some stuff that we could see was going on during that meeting, and then reflecting more deeply on the findings of the research. We offered some strategies, and then this fantastic lady for developing a wellbeing strategy for Tasmania just came up with everything we just said. And she said, this is what we're doing. We're doing this, we're ticking off treasury, we're doing this, we're ticking off intersectoral collaboration at multiple layers, we're ticking off governance. And we were like, okay, great. Well, you're clearly leading the way then, and we'd like to learn from you. I thought it was great. It's really good.
Great. Okay, look, we've sort of come to the end of the session, and I think I'm pretty sure I can speak on behalf of the presenters that it's been really interesting and great discussion. And thanks very much for your questions and your participation and your interest. And we will be trying to publish some of this stuff shortly. We're in the process of writing it up, so we'll keep you in the loop. But again, thanks very much, and we'll hope to sort of discuss some of these issues further in going into the future. So
Thank
you.
you.
All right. Thanks, everyone.